Well, in certain patients that have a low-grade tumor, especially older patients, and they have favorable markers, we like to do Oncotype DX even when they have a positive node, just to see if we really need to do any chemotherapy or they benefit. And I think the data shows that if the recurrence rate is low, that the chemotherapy doesn't really benefit, even with no positive. So we like to use it in selected patients where you think that they really are going to be harmed by chemotherapy more than helped. And so I had a recent patient, she's 71, had a 1 centimeter grade 1 tumor, favorable markers, and so we used Oncotype DX to determine that she didn't really need. She had a small met in her first node, so we just didn't do the chemotherapy. Well, it does a couple of things. One is patients don't really get it very much today, but they like one doctor. And to be able to provide them and shepherd them through that process without having to send them to multiple different people who they might or might not have a lot of trust in or personality issues with, et cetera, but they can get the answer all within the context of what the bond that you've made with them. I think that's very helpful. Nobody wants to go to 14 different doctors to decide whether you need something or not. And if you can do that on the front end, that's great. I love to work with my medical oncology and radiation oncology colleagues, but for the patient's sake, this is very helpful. Almost 2/3 of the patients don't even have to make that extra effort, and just think of the health cost savings with that.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
And I want every woman to know
about personalized breast cancer treatment
and the genomic test.
A test that helps guide a woman and her doctor
to the best treatment options for her.
Pass it on.